Hey everybody, I want to thank Ben for inviting me, and this is actually I think the first year that we're doing the tandem lecture and live demo. So we're going to talk about sono with the hip. I'll give the kind of basic anatomy and transducer positioning, then John will show the appropriate live stuff. So I think it's sad that after 25 years I still have nothing to disclose, but when we talk about the hip, we divide it into 4 anatomic regions. Obviously, they're all right here. But keep in mind that for any body part other than the shoulder, you're doing a focused exam. The shoulder is the only body part where we do a comprehensive exam. So for the hip, if someone has anterior hip pain, there's no reason to be looking at the sciatic nerve or to be looking at their greater trochanteric bursa. You put the transducer where the patient says they hurt and you try and answer that clinical question. For the most part, you can use linear transducers, kind of the mid to higher range. But if you have a very large patient or you're doing a hip injection in a large patient and it's a deep structure, you might have to go to a lower frequency curved transducer. That's rare, but just keep that in your back pocket if you need to. So these are the structures we're going to look at for the anterior aspect of the hip. This is an illustration that I've taken from the ESSR website, and I'll be using these throughout my lecture. So if you take a person's hip and you draw a vertical line, you get the analogous images, which are sagittal MRs. But if you notice, you can't really get the head and the neck nicely in one picture. But with ultrasound, by actually orienting along the neck itself, you can very nicely get the head, the neck, the anterior aspect of the acetabulum. You can get the anterior labrum right here. You see the anterior joint capsule, the overlying iliopsoas. And if you concentrate a little bit on the articulation itself, you can see very nicely the labrum. I'll throw in 2 examples of abnormal to show you what those look like. This is a normal looking head, but you can see that this labrum is torn, it's diminutive. This is a patient with a CAM. You can see that they don't have a nice rounded head anymore. It's flattened, it's dysmorphic, and you can see that this anterior labrum is not only torn, it's actually displaced. If you go into the transverse plane and you slide up the body a little bit, you'll come to the pelvic brim, and you'll see that here on an axial MR. So here's your anterior aspect of the acetabulum. Here's the iliopsoas. This is the corresponding ultrasound image to what you see here. So here's this nicely echogenic iliopsoas tendon. You may have to rock your transducer, not heel-toe it, but you may have to rock it to try and make your beam perfectly perpendicular so that the tendon becomes echogenic and not hypoechoic due to anisotropy. If you slide over a little bit, you'll see that you then have your neurovascular bundle. So the nerve, the artery, and the vein, you can put power on to confirm that. I always think it's kind of cute as I'm doing an iliopsoas bursa injection and my needle is coming from this direction. I always look at the artery and you can see it speeding up in its pulsations as the patient gets nervous. So if you turn longitudinal, here's your transverse image, but if you go long axis, again, you see the iliopsoas nicely lying over the anterior joint capsule of the hip. This is just an example of abnormal. So this is iliopsoas tendinosus. Notice that it's not a uniformly bright echogenic structure anymore. It's heterogeneous. It's also enlarged, so that's tendinosis. And notice the distension of the bursa, which sits almost like a U or a comma around the tendon. If we continue to go up the patient, we now get to the anterior inferior iliac spine. Here's the origin of the direct rectus femoris. This is what it looks like in short axis. So you find your bony landmark, which is your anterior inferior iliac spine. This is the origin of the rectus femoris. This happens to be my needle coming down as I'm doing an injection. Just as an aside, we have 2 different groups of hip surgeons at our institution. We have the arthroplasty guys and we have the hip preservation guys. And they both refer to hip flexors as different things. So you need to know what group of people you're talking to. So when we get a request for a hip flexor injection and it comes from one of our hip replacement guys, we know we need to inject the iliopsoas. When we get a request for a hip flexor injection from one of our hip preservation guys, they mean the rectus femoris. They're both hip flexors, and you got to speak to your clinicians to make sure you're injecting the right thing. And if you turn longitudinal on that short axis, you now see the origin. Notice it's a very short tendinous structure that becomes muscle very quickly. And if you just slide, and you can see that here very nicely on the sagittal MR, there's your direct rectus femoris. If you slide out just a little bit laterally, you'll now see the reflected or indirect head of the rectus femoris, and you see that again nicely on this sagittal MR. Lastly, you go all the way up if you need to. And again, remember, this is a focus exam. There's no reason to look for the lateral femoral cutaneous nerve if, the patient has hip arthritis. But I would say probably every 4 to 6 weeks we get a request to actually inject the lateral femoral cutaneous nerve. It comes from the lumbar plexus, it goes anterior, it travels over the anterior aspect of the psoas, and then it comes out of the pelvis at the level of the anterior superior iliac spine, goes under the inguinal ligament. So this is an axial MR. Here's your sartorius. That's going to be your soft tissue landmark. These two things right here are the nerve. I'll show you a video clip. This is the anterior superior iliac spine. So right here, the nerve is popping into view, right where that tip of the finger is. And this is the anterior superior iliac spine. It's going to come across that. There's the nerve. Now we're going to start to get into the sartorius. That's your soft tissue landmark. Here's the nerve, here's the nerve, here's the nerve. And it's right there. And if we were going to inject, this is where we would catch it. Occasionally, I've been asked to inject it in the pelvis after patients have had PAOs, periacetabular osteotomies. They sometimes get some scarring in that area. But usually, I'm catching it out laterally. Okay, up to you, John.
Okay, Mike, is it on? Okay, thanks, Ted. And so I'll be showing, the first step will be the anterior part. I'll be showing the hip joint, the anterior musculature, and then also lateral femoral cutaneous nerve. So as Ted mentioned, the probe is placed in the sagittal oblique plane like this so that we can actually be in line with the femoral neck and the femoral head. So the bony landmark here is obviously the femoral head where we can see the rounded appearance. Here's the acetabulum. Here's the echogenic fibrocartilage labrum. So when we're looking for a joint effusion or any joint process, we're focusing over the anterior recess as shown here. Now remember that the normal tissue here can be up to 7 millimeters thick, which is essentially the capsule here that comes down and reflects on itself. So it's important not to mistake this normal tissue for synovial hypertrophy or effusion. That's just normal tissue. Also note in this model here, there is irregularity here at the head-neck junction. So when we talk about cam-type impingement, we know that this can be an indirect sign, but we also know that this finding can be seen in asymptomatic people. So I would look at this, I would look for a labral tear. My clinician would then correlate clinically for femoroacetabular impingement. The model here is asymptomatic, but she is an athlete, so this could relate to that. One other point about the hip joint is that the distribution of joint fluid is such that screening the anterior hip is usually adequate. There are no cases where fluid is only pooling posterior in the native hip. Now, after surgery, all bets are off where fluid can be loculated anywhere. Okay, the next thing I'm going to do is show the anterior musculature. What I'm going to do is send over the femoral head. I'll turn 90 degrees. The neurovascular structures will be on the right. And the large muscle tendon unit that we see anteriorly is the iliopsoas complex. What I am then going to do is move proximally up to the ilium. So if I come up to here, I have a continuous smooth bone landmark of the ilium. And this is my landmark where I can see the iliopsoas complex. Here's the rectus femoris direct head on the anterior inferior iliac spine. Note here that this is actually the psoas major tendon, the psoas major muscle, and then this is the iliacus lateral and medial aspects. So this is the view if I were injecting, if I were looking for a snapping hip, I can show you how I would do that. So if you can bend at your hip, keep bending for me. So with the hip bent like this may not show well, actually it's not. And then bring the leg over like this. So the patient's in a frog leg view, and then when the leg is extended, go ahead and straighten your leg. That's when the snapping would occur. Now remember that the snapping occurs because the medial part of the iliacus muscle gets entrapped underneath the psoas major tendon. So we would be looking for that. So centering over the rectus femoris direct head, I can turn 90 degrees and look at this in long axis like this. There we can see the direct head. Now for the indirect head, what I do is I center over the direct head and move lateral. So basically over the lateral acetabulum. And then you move the transducer into 30 degrees. And what this will do is then bring the indirect head into its long axis plane, which is right here. Okay. So the last thing I'm going to show is going to be the lateral femorocutaneous nerve. Now most of the time this nerve is going to track over the top of the sartorius. So there are different ways of trying to find this nerve. Of course, if it's abnormal and it's thickened, it's easier to find. One thing you could initially do is just by scanning over the top of the sartorius back and forth, your eyes will see these small nerve fascicles here going over the top. So if I go from distal to proximal, the nerve fascicles are going to move medial right here, and then eventually come more medial and go underneath the inguinal ligament. Now, if you can't see the nerve in that mode, the other thing you could do is if you come more distally, there's always a fatty triangle located here, lateral to the sartorius. Within that fatty triangle, there's always a branch of this lateral femorocutaneous nerve. So one thing I could do is see that nerve branch, and then now move the transducer proximally, and you can track the nerve fascicles, then again going over the top, going from lateral to medial. So you see those tiny fascicles moving over the top. So that's the anterior hip.
Okay, good. Let's continue on. Probably most of the time is going to be spent with your anterior aspect of the hip. Can we bring my slides back up? Thanks. And then the lateral side of the hip. So bony landmark for the lateral side is your greater trochanter, and the structures that we're going to look at are these four things. So if you put your transducer short axis, which is how I start looking for the greater troch, I always go short axis first. And if you put up a corresponding axial MR, that's the bony landmark that you're looking for, that little promontory between your anterior and lateral facets. And then notice your rounded facet posteriorly. This is the corresponding short axis ultrasound. So again, that little promontory, that's my bony landmark, because I know that anterior to it, that's the anterior facet with the gluteus minimus insertion, and then behind it is the lateral facet with the anterolateral footprint of the gluteus medius. Overlying it's going to be the iliotibial band. The greater trochanteric bursa is going to be sitting in between that. So this is a nice illustration from Christian Fearman's article a million years ago now. It seems like a whole nother lifetime. And he's outlining the greater troch bursa here, which is going to go anterior or superficial, actually, superficial to the abductors. And you can see that here very nicely with my needle in place, that here are your abductors. Again, there's that little bony prominence. Here's your iliopsoas. Here's your iliotibial band, and then this is the greater troch bursa that's filled with fluid. Sometimes if you scan a patient, you'll see a little bit of fluid collecting more posteriorly. That's in the dependent portion of the bursa. And again, you see your iliotibial band very nicely sitting on top of your abductor tendons. If you go on the long axis, so I find my short axis first, and then I just go long, it's going to give you this analogous picture to a coronal MR. And you put your transducer longitudinally on it, and you get an image like this. So this is your coronal MR. You rotate it a little bit, and now hopefully you'll understand the anatomy. Here's the greater troch. This big muscle here is your gluteus medius. Deep to it is the gluteus minimus with its tendon right here coming to insert on that anterior facet of the greater troch. If you just slide a little bit posteriorly, you get an image like this, and again, this corresponds to what we're seeing on the longitudinal ultrasound. Big muscle, which is the gluteus medius, coming down with its tendon here onto the lateral footprint of the greater troch. And then, of course, if you scan up and down a little bit, this is an extended field of view image, you can see very nicely the iliotibial band riding superficial to that. Okay, John?
Okay, so I have the patient laying on the side, and what that does is essentially rotate the greater trochanter directly up. So I put the transducer, as Ted mentioned, short axis to the femur. So the leg can be bent a little bit or not, it doesn't matter as long as you're short axis. I'm going to just move the transducer over the top of the greater trochanter until I identify this apex, like a roof of a house, which separates the anterior and lateral facets. So you can see I'm short axis on the femur. So once I've identified these facets, we know this is the gluteus minimus anteriorly, this is the gluteus medius on the lateral facet, here is the iliotibial tract or band, and the posterior facet, as I move the transducer more posterior, is the gluteus maximus, which doesn't attach on the posterior facet, but attaches more distally on the femur. So it's important when looking for bursal distension that the subgluteus maximus bursa, or what's called the trochanteric bursa, it tends to be posterior, although if it's distended, it will usually go between the gluteus medius and then under the iliotibial tract or band. So once I've identified these bone landmarks, I can then isolate each tendon. What I'm going to do is center over the gluteus minimus, Note how I'm moving the transducer over to the anterior hip such that the anterior facet is perpendicular to the sound beam. This makes it easier to locate the tendon when I turn 90 degrees. So if I turn long axis like this, we can see the anterior facet here, and we can see the gluteus minimus on top of that, and here the iliotibial tractor band. This is the gluteus medius muscle. This almost looks like the rotator cuff of the humeral head and the greater tuberosity, and hence that's another reason they call it the rotator cuff of the hip. Note that when I'm looking at the gluteus minimus, I'm angling somewhat anterior. Now when I come back to the gluteus medius, I'm going to be angling somewhat posterior, so it forms like a V on the greater trochanter. So that's the gluteus minimus. Now to get to gluteus medius, I'll go to my starting point again, find the apex, and now I'm going to go perpendicular to that lateral facet. I'll then turn long axis, again angling back, and what we see here is the gluteus medius tendon over the lateral facet, which is usually thinner than gluteus minimus. And then as I work my way more posterior, I'm going to look at the other part of the tendon, which attaches to the superior posterior facet. So you can see I'm really coming back like this. And if I try to hit this area at 90 degrees, you'll see the tendon attaching right here. Now, this often looks hypoechoic. It's important not to overcall that as tendinosis. So that is the gluteus medius. And that's it for the lateral hip.
Okay. Good. So now we'll go posterior. Patient's laying prone. The bony landmark for that is going to be ischial tuberosity. Here you can see on a longitudinal, on a coronal MR, here on a short axis MR. And then the soft tissues around it are going to be those that are listed here. But we're going to use the ischial tuberosity as our bony landmark to find those things. So now patient's lying prone. You can either start short axis or long axis. I just happen to have the cursor here going long axis. You get an image that looks like this. Again, a sagittal MR. If you rotate that 90 degrees, that's the orientation that you're going to be seeing with ultrasound. You get your longitudinal picture right here. Ischial tuberosity, hamstring, hamstrings. Now, if you slide a little bit more medial on the tuberosity, you're going to get into the conjoined tendon portion of the hamstrings. If you slide out a little bit more lateral, you're going to get more into the semimembranosus portion. And remember, these are not just lines, they're really bands of tissue. So you really do have to sweep back and forth through them to see the entire dimension of this structure. If we take our transducer and we put it short axis, and usually the crease of the buttocks is a good soft tissue landmark for where to start, but again, everybody's anatomy is a little bit different, and where their butt lies is a little bit different, so you may have to sweep up a little bit, up and down, just try and make sure you're doing it in a professional fashion. So here you can see the ischial tuberosity, here are your hamstrings, here's the quadratus femoris, overlying gluteus maximus, here's the sciatic nerve. And this is the corresponding short axis ultrasound. Again, bony landmark, ischial tuberosity, hamstrings, which often look hypoechoic even when they're completely normal. I think that ultrasound of the hamstrings is very challenging because I don't think we visualize them well. But if you had ischial bursitis, it would be right in this area here. And again, sciatic nerve is here, quadratus femoris is here. But I'm concentrating in this particular image on the ischial tuberosity. If we want to look at the sciatic nerve, and we probably get asked to do this about once a month, you put the transducer again over the buttocks. You're going to look for your bony landmark of the ischial tuberosity. And then you can also use the femur as your landmark as well. So here's ischial tuberosity. Here's your hamstring origin, gluteus maximus, quadratus femoris, and this is the sciatic nerve. And again, you may have to scan up and down the ischial tuberosity a little bit and the back of the pelvis to see where this nerve is the best. And you may have to rock your transducer, not necessarily heel-toe it, but rock it a little bit to make the nerve echogenic. So just as an aside, I was sitting in this meeting, I don't know, a couple of years ago at the SSR, and somebody got up and they showed, they presented a case of using CT guidance to inject the sciatic nerve, and someone else got up and said, no, don't ever use ultrasound for that because it could be really dangerous. So I immediately texted my junior colleagues back at HSS and said, go back and look at the last 5 years of how many of these we've done. We published this a couple months ago. We did 237 sciatic nerve injections. We never piffed anyone. We didn't paralyze anyone. It's completely safe to do. As long as you can see the nerve and see your needle, you can do this. You can turn your transducer longitudinally, and again, that's the corresponding sagittal MR, and you see the nerve right here very nicely. And here's the sciatic nerve in longitudinal. And then lastly, we will occasionally be asked to evaluate patients sonographically if the clinician thinks they have ischiofemoral impingement. So the patient's laying on their belly. I typically have their foot hanging off of the stretcher so that they can internally and externally rotate their lower extremity. Your bony landmarks are the ischial tuberosity and the posterior aspect of the femur. This is the quadratus femoris. This is the iliopsoas. So if you internally and externally rotate them, so this is actually internal rotation. They're turning their foot in. The back of the femur is going to rotate outward, and it's going to stretch out the quadratus femoris. So you can see very nicely here's the sciatic. And when you externally rotate them, that's when you squash the quadratus femoris against the ischium and the bone. Just like there. And then you ask the patient, is that your pain? Does that recreate your symptoms? And if it does, then, the clinician has to correlate that with their physical exam as well. So we get asked to inject these sometimes with, just as a diagnostic with lidocaine and marcaine to see if that makes the patient's symptoms go away. So here's the patient pre-injection. Again, my bony landmarks, posterior aspect of the femur, ischium, sciatic nerve. I want to stay away from that. And here's because I'm not trying to numb them up. They don't have sciatica, they have impingement. So our targets are different things. This is the quadratus femoris. So here's my needle coming down. Notice that I'm centering more over the back of the femur. The sciatic nerve is over here, so I don't want to numb that up. And I'm going to lay a little bit of lidocaine in here, and you can see that's my lidocaine that I've put there. Now I've put my needle actually deep to the muscle, and I've put some lidocaine in there as well. So here you can see compared your post-injection to your pre-injection. This is lidocaine and marcaine, this is lidocaine and marcaine compared to what it looked like before I stuck my needle in it. And then this patient happened to get relief. Okay, John?
All right, thanks, Ted. So looking at the hamstring, we'll be starting short axis to the buttock area. Let's make sure you can see everything here. Now, there are two different starting points for looking at the hamstring. One is at the ischial tuberosity. You could palpate it, or you can just find the bony landmark. So you can see I'm short axis to the femur, and medial or midline is to the right, lateral to the left. And here we see the ischial tuberosity. The sciatic nerve is down here. Now remember that the two tendons that attach here, the one that sits around, let's say 11 o'clock, is the conjoined attachment of the semitendinosus and long head of the biceps femoris. So that's located more superficial. The one that's more lateral down the slope down here is the semimembranosus. They often look hypoechoic, and as you know, just like an MR, they often look gray, and it's an asymptomatic finding, so make sure you don't overcall tendinosis. To get around that, I'm going to move the transducer more to the lateral aspect and try to hit that bone at 90 degrees. You can see when I come from the side a little bit more and toggle the transducer, the tendon's becoming more echogenic. So a rule of thumb is when looking at all these structures, if you can hit the bone at 90 degrees, you're more likely going to eliminate anisotropy of the overlying tendon at its footprint or attachment. Now, of course, we can now look at these two structures in long axis. Here's ischial tuberosity. Remember, if I'm around the 11 o'clock position, this is going to be the conjoined attachment of those two tendons, semitendinosus and biceps femoris long head. Here we can see that appearance right here. Now, if I'm going to be looking at the semimembranosus, I have to actually move lateral. But remember, I'm coming down the slope, so to hit it perpendicular, I'm actually going to come in from the side a little bit when I'm looking at it from a long axis approach. And that would be right here, the semimembranosus. Okay, the second way of looking for the hamstring is to put your probe in the horizontal gluteal crease here. Because where that will come into play is when you've torn off your hamstrings and there are no tendons up there to be seen, so we need another starting point. So if you put the transducer right in this horizontal crease and you toggle the transducer, you usually see a triad of structures. We're going to have midline or medial to the right, lateral out here. And what we're going to see is this is the muscle, the semitendinosus. This tadpole type structure or shape structure is the semimembranosus tendon and aponeurosis. Here's the sciatic nerve, and this is the conjoined tendon starting to form. So we have 1, 2, 3 structures. Conjoined tendon between the biceps femoris long head and semitendinosus, the sciatic nerve, and the semimembranosus tendon and aponeurosis. And one thing that's key is when you put your transducer in this approach, you have to toggle the transducer. If you move it just even 3 degrees, those 3 landmarks completely disappear. So when you put the transducer down, I instantly just start toggling, and then these tendons and that sciatic nerve will pop into view. So that's another way of getting your orientation. And then as we move proximally, we know that the semimembranosus tendon is going to go underneath the conjoint tendon. Here's the semimembranosus, here's conjoint tendon right there. And now they're starting to crisscross where the conjoint is on top of the semimembranosus. And then we get up here at the top where around 11 o'clock there is the conjoined semitendinosus biceps femoris longhead, and here again the semimembranosus. One last thing is when you're looking at the sciatic nerve, we're looking at that in long axis. It almost looks like a tendon, so make sure you don't mistake that because it can almost look like it. Okay, back to you, Ted.
Good. Okay. So we'll finish up with the medial area of the hip, which is really your hip adductors. I'm not really going to talk about the symphysis pubis. To me, that's a different kettle of fish. But these do go between your femur and your symphysis, so you may wind up scanning that area at some point. So for this, the patient is abducted and externally rotated. You're going to be putting your transducer longitudinally like this, and again, you will see those muscles very nicely. They kind of make a fan shape right here. So this is medial, where the symphysis would be here. Femur is going to be down here, and if you slide your transducer up toward the symphysis, you will now get that area here, and you'll see the adductor longus as it's coming over the anterior aspect of the pubic bone to go to the symphysis pubis, where it'll blend with the rectus abdominis. If you go short axis, again, you see those muscles very nicely in transverse. And we occasionally get, in soccer players will sometimes, or football players, they may have tears here. We'll be asked to evaluate for tear. We may be asked to inject or to aspirate a hematoma. And again, you just slide proximally a little bit and you'll come to the bone of the symphysis itself. I'll just finish with my summary, and then John will do his demonstration. But what I hope that the two of us have shown you is that many of the areas of clinical concern in and around the hip really can be seen with ultrasound, not just with MR. But remember, it's a focused examination targeting one of these particular areas, and even within those, one of those particular sites. Thank you. John?
Okay, so for the medial aspect, there are 2 different starting points. One is you could start at the symphysis pubis, which I'll skip that for the patient's sake here. The other one is to start in the mid-thigh. Now remember that most of these problems are going to occur at the symphysis, and where the rectus femoris comes down and the adductor longus comes together as a common aponeurosis. That's the most common type of injury we see. So starting in the mid-thigh for orientation and working our way up, what I tend to use is the sartorius and neurovascular structures as my starting point. So I'll have medial on the right side of the screen. Here we can see the sartorius over the neurovascular structures. If I simply move the transducer medially and then work my way just more proximal, what we'll do is we'll see 3 different layers of muscle. We have one more superficial, the next one, and the next one. This is the adductor longus, brevis, and magnus. In between that, you can see these fascial planes, and in these fascial planes are the anterior and posterior branches of the obturator nerve. Their fascicles will be coming through here. But you can see nicely this order of longus, brevis, magnus. The mnemonic some people use is Alabama, where AL, AB, AM, so it's longus, brevis, magnus. I can then turn long axis on these structures, and again we'll see 3 different layers. Here we'll see the obturator nerve branches, anterior and posterior. And then you can keep tracking this up more proximally, which I'm not going to do for this demonstration, but you can track those tendons to the origin. Okay, that's it for the medial part. All right, so thanks for your attention. Any questions for Ted or myself?
When you do ischiofemoral impingement injections, you describe that you do the injection, radical injection, superficial into the derived femoral muscle. When you inject for ischiofemoral impingement syndrome, you describe that you do an injection, radical injection, superficial into the traversing.
Yes, to the quadratus. So the question was, when we do a diagnostic injection for ischiofemoral impingement, where am I putting my needle? Yes, I'm putting it along the superficial aspect of the quadratus femoris muscle, staying away from the sciatic nerve because I don't want to numb up their nerve. And then I go through the muscle and go deep to it and inject there as well. Because when it's getting impinged, both the superficial and the deep sides are getting squashed. So I want to numb up both sides.
That lidocaine that you placed on top of the muscle, does it track to the sciatic nerve?
It may. I mean, you know, we actually did a cadaver study several years ago that we published, just injecting around nerves, and 2 cc's around a small nerve will actually have a 6 centimeter throw either way, and 5 cc's will actually go about 12 centimeters either way. So yes, some of it does. But since we're not really targeting the nerve and we're not trying to get circumferential flow around the nerve like I would if I was doing a periostatic nerve injection, they tend not to get that numbness as long as I'm staying away from the nerve. It may track under it, but it's not going to numb them up the way it would if I were actually targeting the nerve.
And I also want to thank our model Mariah for her patience in letting us scan her, so thank you. Okay.
All right, good luck, guys.